Sa panahon ngayon, iba na. Ang karaniwang araw ng bawat Juan, Pedro at Maria ay makipagkita na lang sa internet. Pero paano kung biglaang magkasakit si Pedro? Nangangati, may mga butlig at unti-unti nang di makakita. Ano na ang gagawin? Maaaring mayroon ng tinatawag na shingles o kulebra si Pedro. Maliban sa katawan, pwede itong makaapekto sa mukha at mata. Paano nga ba nagkakaroon ng kulebra? Ito ay isang sakit na nadudulot ng isang virus. Itong virus rin ang sanhi ng chickenpox o bulutong tubig sa mga bata. Maski gumaling na ang bulutong tubig, ang virus ay nananatili sa mga ugat o nerves. Sa pag-edad at pagkakasakit, maaaring magising muli ang virus at magdulot na naman ng sakit na tinatawag na shingles o kulebra. Hindi ito tulad ng bulutong tubig na nakikita sa buong katawan. Ang pananakit at putlig-putlig ng kulebra ay nakikita lamang sa isang parte ng katawan. Kapag ang isang tao ay nagkaroon ng kulebra sa may parte ng muka, ay pwede nitong maapektuhan ang ating mata o ang tinatawag na herpes zoster ophthalmicus. Maliban sa mga butlig sa muka, maaaring magkaroon ng lagnat, pananakit ng ulo at mata, pagluluha, pamamaga ng talukap ng mata, at pagiging sensitibo sa ilaw. Sa mga ganitong pagkakataon, maaari nang magsuspetsya ng herpes zoster ophthalmicus. Ano ang iyong gagawin kung may herpes zoster ophthalmicus ka nga? Mainam na kumonsulta agad sa iyong doktor o sa isang espesyalista sa mata upang maagapan ang potensyal na pinsala sa cornea. Ang HZO ay ginagamot gamit ang antivirals. Ang mga ito ay pumupuksa sa mga virus na nagdudulot ng HZO. Maaari rin mabigyan ng steroid para sa mata upang malunasan ang inflammation o pamamaga. Nakakahawa ang kulebra, kaya dapat maagapan ito ng maaga. Mahalagang ma-diagnose ng maaga ang impeksyon upang mapigilan ang pagtuloy nito sa HZO. Mas maganda kung maiwasan ang impeksyon sa pamamagitan ng bakuna laban sa varicella zoster virus. Ginagamit din ang varicella immunoglobulin upang maiwasan ang mga epekto nito kung na-expose sa taong may aktibong impeksyon. Sa panahon ngayon, iba na. Ang karaniwang araw ng bawat Juan, Pedro at Maria ay makipagkita na lang sa internet. Pero paano kung biglaang magkasakit si Pedro? Nangangati, may mga butlig at unti-unti nang di makakita. Ano na ang gagawin? Maaaring mayroon ng tinatawag na shingles o kulebra si Pedro. Maliban sa katawan, pwede itong makaapekto sa mukha at mata. Paano nga ba nagkakaroon ng kulebra? Ito ay isang sakit na nadudulot ng isang virus. Itong virus rin ang sanhi ng chickenpox o bulutong tubig sa mga bata. Maski gumaling na ang bulutong tubig, ang virus ay nananatili sa mga ugat o nerves. Sa pag-edad at pagkakasakit, maaaring magising muli ang virus at magdulot na naman ng sakit na tinatawag na shingles o kulebra. Hindi ito tulad ng bulutong tubig na nakikita sa buong katawan. Ang pananakit at putik-putlig ng kulebra ay nakikita lamang sa isang parte ng katawan. Kapag ang isang tao ay nagkaroon ng kulebra sa may parte ng muka, ay pwede nitong maapektuhan ang ating mata o ang tinatawag na herpes zoster ophthalmicus. Maliban sa mga butlig sa muka, maaaring magkaroon ng lagnat, pananakit ng ulo at mata, pagluluha, pamamaga ng talukap ng mata, at pagiging sensitibo sa ilaw. Sa mga ganitong pagkakataon, maaari nang magsuspetsya ng herpes zoster ophthalmicus. Ano ang iyong gagawin kung may herpes zoster ophthalmicus ka nga? Mainam na kumonsulta agad sa iyong doktor o sa isang espesyalista sa mata upang maagapan ang potensyal na pinsala sa cornea. Ang HZO ay ginagamot gamit ang antivirals. Ang mga ito ay pumupuksa sa mga virus na nagdudulot ng HZO. Maaari rin mabigyan ng steroid para sa mata upang malunasan ang inflammation o pamamaga. Nakakahawa ang kulebra, kaya dapat maagapan ito ng maaga. Mahalagang ma-diagnose ng maaga ang impeksyon upang mapigilan ang pagtuloy nito sa HZO. Mas maganda kung maiwasan ang impeksyon sa pamamagitan ng bakuna laban sa varicella zoster virus. Ginagamit din ang varicella immunoglobulin upang maiwasan ang mga epekto nito kung na-expose sa taong may aktibong infeksyon. Sa panahon ngayon, iba na. Ang karaniwang araw ng bawat Juan, Pedro at Maria ay makipagkita na lang sa internet. Pero, paano kung biglaang magkasakit si Pedro? Nangangati, may mga butlig at unti-unti nang di makakita. Ano na ang gagawin? Maaaring mayroon ng tinatawag na shingles o kulebra si Pedro. Maliban sa katawan, pwede itong makaapekto sa mukha at mata. Paano nga ba nagkakaroon ng kulebra? Ito ay isang sakit na nadudulot ng isang virus. Itong virus rin ang sanhi ng chickenpox o bulutong tubig sa mga bata. Maski gumaling na ang bulutong tubig, ang virus ay nananatili sa mga ugat o nerves. Sa pag-edad at pagkakasakit, maaaring magising muli ang virus at magdulot na naman ng sakit na tinatawag na shingles o kulebra. Hindi ito tulad ng bulutong tubig na nakikita sa buong katawan. Ang pananakit at putik-putlig ng kulebra ay nakikita lamang sa isang parte ng katawan. Kapag ang isang tao ay nagkaroon ng kulebra sa may parte ng muka, ay pwede nitong maapektuhan ang ating mata o ang tinatawag na herpes zoster ophthalmicus. Maliban sa mga butlig sa muka, maaaring magkaroon ng lagnat, pananakit ng ulo at mata, pagluluha, pamamaga ng talukap ng mata, at pagiging sensitibo sa ilaw. Sa mga ganitong pagkakataon, maaari nang magsuspetsya ng herpes zoster ophthalmicus. Ano ang iyong gagawin kung may herpes zoster ophthalmicus ka nga? Mainam na kumonsulta agad sa iyong doktor o sa isang espesyalista sa mata upang maagapan ang potensyal na pinsala sa cornea. Ang HZO ay ginagamot gamit ang antivirals. Ang mga ito ay pumupuksa sa mga virus na nagdudulot ng HZO. Maaari rin mabigyan ng steroid para sa mata upang malunasan ang inflammation o pamamaga. Nakakahawa ang kulebra, kaya dapat maagapan ito ng maaga. Mahalagang ma-diagnose ng maaga ang impeksyon upang mapigilan ang pagtuloy nito sa HZO. Mas maganda kung maiwasan ang impeksyon sa pamamagitan ng bakuna laban sa varicella zoster virus. Ginagamit din ang varicella immunoglobulin upang maiwasan ang mga epekto nito kung na-expose sa taong may aktibong impeksyon.
Hi, good afternoon to all our viewers. It feels good to be back for another episode. It was such a great experience hosting the previous episode of EyeTV that I had to do it again. But this time, it will be with a section that I am very much proud to be a part of. So for the first time on TMC EyeTV, I would like to welcome you all to this episode prepared by the Orbit and Oculoplastic section of the Medical City Eye and Vision Institute. Of course, just like any other episode, we will first listen to some words of welcome to be given by Dr. Alfonso Bengzon from the Plastics, Lacrimal, and Orbit section of the Medical City Eye and Vision Institute.
Good afternoon to all our colleagues in the Philippines, as well as all our international viewers. For the past year, the Medical City's Eye and Vision Institute EyeTV program has been a platform that has been producing very informative and educational shows. These shows have benefited ophthalmologists in training, as well as practicing ophthalmologists. Such is the basic purpose of EyeTV, the vision of our Institute's director, Dr. Victor Caparas. The section of ophthalmic plastic, lacrimal, and orbital surgery of the Eye and Vision Institute has been eagerly waiting for its chance to contribute to this initiative. And now that time has finally arrived. So for today's topic, we've chosen something that we feel would be applicable and relevant to any and all ophthalmologists in their clinical practice. And at the end of the show, we hope that everyone will have taken home something that would further add value to the service that you provide to your patients. So it is my pleasure and honor to welcome you all to this edition of EyeTV, brought to you by the section of ophthalmic plastic, lacrimal, and orbital surgery, led by our section head, Dr. Ken Lagunzad, and Senior Staff Consultant Dr. Gary Mercado. Of course, ably supported by the rest of our PLO service consultants. Thank you all for watching and enjoy the show.
Thank you very much, Dr. Vangzon. So, let us now get into the meat of this afternoon's topic. As what you have seen in the beginning, the focus of this episode will be all about the lids. This includes common lesions that we see, as well as their appropriate management. Today, we are very, very fortunate to have all of our PLO consultants with us, as they have prepared very interesting lectures and discussions that will benefit you as an ophthalmologist in general. So our first speaker for this afternoon is Dr. Mariel Parulan, or as we fondly call her, Doc Rian. Doc Rian is a graduate of the Ateneo School of Medicine and Public Health. She then trained at Quirino Memorial Medical Center for her ophthalmology residency and subsequently did her fellowship training in ophthalmic, plastic, and reconstructive surgery at the National University Hospital, Singapore. She's currently a PLO consultant at both Quirino Memorial Medical Center and the Medical City. After her lecture, we will have an in-depth and interactive case discussion by our consultants to be moderated by no other than Dr. Gary Mercado himself. I think Dr. Parulan is ready. So let us begin. Dr. Yan?
Hi, Pia. Thank you for that very kind introduction. Okay, so let me just share my screen. Okay. All right. Good afternoon to everybody. Thank you to TMC EyeTV for inviting me today to give this talk on a conceptual approach to the diagnosis of eyelid tumors. So basically, this will be the outline for this discussion. And this is how we will approach it. So first, we start with basic fundamentals, we put it into context, and then we apply these in the clinical setting with our patient. So anatomy is quite central to making the right diagnosis, because as you will see later, we can classify the different types of tumors according to this. It's important to stress that the eyelid is composed of both skin, mucous membrane, and supporting adnexal structures. Most anteriorly, we have the three layers of the skin, the epidermis, dermis, and subcutaneous tissue, which is almost invisible in the eyelid, and together with the orbicularis muscle, it forms the anterior lamellae. Posteriorly, we have the tarsus and conjunctiva to form the posterior lamella. This is just a magnified view of the sagittal tarsal edge, showing conjunctiva, tarsal plate containing the meibomian glands, and pretarsal orbicularis. Along this tarsal margin, you will also find pilosebaceous units where you will find hair follicles and other sebaceous and sweat glands of the eyelid. I will not go into the detail of this, but suffices to say, neighboring structures of the lid are equally important because this may be the origin of some presenting lid tumors. So now we classify the tumors of the eyelid. As mentioned, we can categorize this by anatomy and can be grouped accordingly. So we include also here inflammatory and infectious types, which also present as lid lumps. This is just a list of the common epidermal, adnexal, and cystic tumors of the eyelid, including both benign and malignant ones. One of the most common tumors of the eyelid arise from the epidermis. They can be grouped into melanocytic and non-melanocytic types. Among the common non-melanocytic types are your squamous papilloma, your seborrheic keratosis, and your keratoacanthoma. Actinic keratosis should be recognized because although benign histologically, they belong to the spectrum of squamous cell carcinoma. In the epidermis, we also have the pigmented tumors, and among them, the most common would be the acquired melanocytic nevus. They evolve in location and appearance and appear differently depending on their life stage, and these are the following types and their corresponding locations in the skin. There's also the congenital type, which has slightly more distinct clinical features. They are present at birth, darker and more nodular with age, and occasionally with coarse hair. Most of the common malignancies of the lid are thought to arise from the epidermal layer, and hence important key features are important to identify. Among them, the most common would be your basal cell carcinoma. Filipinos who are often under the sun are more likely to have this, especially farmers and fishermen, because UV exposure is one of its risk factors. It's more common among men within the 40 to 79 age bracket, and its most common and classic presentation is the nodular type with pearly appearance and rolled borders. So that's what you would see classically in textbooks. It may also be ulcerated, pigmented, infiltrative, or cystic. Other key features to identify include your telangiectatic vessels, your central necrosis, and your ulceration. Sometimes it may also be associated with eyelid deformities and lid malpositioning or loss of lashes. So these are things that we don't normally see in benign lesions. Second to this would be your squamous cell carcinoma. Its extrinsic risk factors include UV exposure, similar to BCC, actinic damage, exposure to radiation, or immunosuppression. Patients with albinism, pre-existing or chronic skin disorders are also more prone to this tumor. They are more commonly seen among fair-skinned elderly patients, and its key features would include painless, elevated nodular plaque-like lesions. It may also present with scaling and fissuring of skin. You may also have that grayish-white granular appearance from keratin in well-differentiated tumors, and there may also be ulceration with madarosis and loss of lid architecture, especially when it's noted on the eyelid margin. And finally, the last among the three is your malignant melanoma. So it has the least prevalence, especially in our local setting. It's more common among elderly Caucasians with increased sun exposure. Sometimes they may also come from pre-existing levi. So for pigmented lesions, it's of utmost importance to determine if it's malignant or not. As we know, malignant melanoma, although it's quite rare in the eyelid, it may be fatal if missed. It actually causes 75% of total deaths due to skin cancer. So a good guide to its clinical features would be the ABCDE mnemonic. So A stands for border asymmetry, B for border irregularity, C for color variation, both intralesionally as well as color that's different from the patient's other nevi, diameter greater than 6 millimeters, and if it's evolving or it's elevated. So for example, in this pigmented lesion, note the irregular border, the variegated shades of brown, gray, bluish hues, and the apparent overlying ulceration. A proposed alternative to this is the ugly duckling sign. So this states that the spot that is unlike the others is the most suspect for malignancy, which is actually the same for most malignancies in the eyelid. Okay, so beneath the epidermis, adnexal tumors may arise frequently because the eyelid is rich in these structures. So we have cystic lesions along the dermal epidermal layers, the hair follicle tumors, your sweat gland tumors, and the oil gland tumors. Most commonly among the cystic tumors are your epidermal inclusion cyst and milia. I think most of us are familiar with this. Example of hair follicle tumors are your pilomatrixoma, which is common in children, and your tricholamoma, which is common in adults. Among the sweat gland tumors, there are the apocrine hydrocystoma, which are usually marginal and transilluminates, while ecrine hydrocystoma are non-marginal and appear as small clusters of cysts. And then we have the common syringoma, which appear as waxy papules. Among benign sebaceous gland tumors are your sebaceous hyperplasias and sebaceous adenoma. Sebaceous hyperplasia appear as small yellowish papules with umbilicated central depression and occasional telangiectasias. Occasionally, the lids may appear thickened and may develop ectropion. Sebaceous adenomas are rare and appear as yellowish-reddish papules around 5 millimeters in size. It rarely can form at the posterior lamella and may present as a recurrent lid mass resembling chelation, and sometimes that's when it gets a little bit tricky. We should also include inflammatory lesions that present as lid tumors, and this includes chelation, which I think most of us ophthalmologists have encountered, infectious viral lesions such as molluscum contagiosum and your verruca vulgaris. Malignant lesions may mimic these inflammatory and adnexal lesions, and the important differential include your sebaceous gland carcinoma. So actually, this has the same prevalence as basal cell carcinoma in our local setting, as I will show later. Sebaceous gland carcinoma is a potentially lethal tumor that arises from meibomian glands, glands of Zeiss, and the sebaceous glands of the ocular adnexae. It's more common in elderly females, but can also be seen in post-radiation retinoblastoma patients. It appears as firm, painless subcutaneous lesion that mimics chelation or chronic blepharitis. So in this photo, appreciate the sessile round nodule fixed to the tarsus, and they may have that yellowish color due to lipid content and may reveal loss of cilia or madarosis, as we call it, effacement of your meibomian glands, and diffuse thickening of the lid margin. So just to quickly differentiate, chelations are seen usually in younger patients and are well circumscribed. They may start out as painful lesions and usually will not present with loss of cilia. For inflammatory lesions, it's also similar. They are more acute, painful, and more importantly, they respond to therapy. So if it doesn't and it presents in middle-aged or older patients, you have to suspect malignancy. So after reviewing our basics, we now go to epidemiologic data and see which are the more common ones seen in our respective settings. Okay, so fortunately, it's still the benign ones that we often see in the clinics, and they are mostly the same across the border. So some differences exist, but relatively most of them are epidermal in origin. Okay, so just a word of caution, always keep in mind there's always that small chance that it might turn out to be malignant. So in this 10-year review of patients here in the Philippines, out of the 530 lid tumors identified, 68% are benign and 32% are malignant. So among the most common benign tumors in the local setting, these are the top ones. And for malignancies, that's what comprises the 32%. And as you can see, basal cell and sebaceous gland carcinoma are of the same prevalence, followed by squamous cell carcinoma and melanoma as the least prevalent. So this is important because these are the first differentials to consider when we have patients that present with eyelid tumors in our clinic. Finally, we can make our clinical assessment and diagnosis of our patient. Okay, so we all know we get important clues from a focused history. We have to investigate on the onset, whether it's acute or chronic, symptoms, if it's tender, is it a painless, slow-growing mass, is it evolving? And if so, you have to ask about risk factors that predisposes one to malignancies, and I think I've mentioned some of them already. With eyelid tumors, it's mostly about pattern recognition, and rarely will imaging be required. Location would give clues to the etiology of the lesion, such as in your dermoid cyst. So we know that it's commonly seen in the superlateral aspect because of your frontozygomatic suture line. We also look at surface features because some have distinct characteristics like the sandy paper texture and actinic keratosis. We also check surrounding skin because erythema may allude to an infection and not really a neoplastic etiology. Mobility determines if it's epidermal or subdermal, like in your pilomatrixoma. Color, which I mentioned already, is telling of malignancy. So we look for that uniform color pattern, contrary to variegated ones in melanoma. We also check for fluid-filled swellings in apocrine hydrocystoma that transilluminates. And finally, size, to monitor progression and whether it's aggressive enough to invade surrounding structures. So in summary, we start with basic fundamentals, we put it into context, and perform a thorough history examination of our patient to make our clinical diagnosis. If there's one thing to take home, it's that we should always be mindful of these red flags. Remember the distortion of lid margin and loss of lashes, recurrent chelation that will not improve with usual therapy, ulceration, which may be a sign of evolving lesion from a chronic inflammatory condition to a malignant one, the irregularity of borders, especially in pigmented lesions like melanoma, the pearly border, which is very distinct of basal cell carcinoma and which is actually the most common lid malignancy across all borders, bleeding also in the same light as ulceration, and diplopia and proptosis, because this may tell you that the tumor has extended and probably involved structures already beyond the eyelid. So these are just simple clinical pearls that that will make you raise your suspicion of a more sinister kind of tumor, which at the end of the day will be life-saving for your patient. So I hope you were able to pick up something from this very short overview of clinical assessment of eyelid tumors. Thank you.
Thank you very much, Dr. Ian, for your very comprehensive lecture. So before we proceed, I would like to remind our viewers not to forget to fill out the attendance sheet. And if you have any questions at all, don't forget that you can put them in the comment section, and we will address them towards the end of this episode. So I will now turn you over to our very own Dr. Gary Mercado for the next segment. So Dr. Mercado is a graduate of the College of Medicine of the University of the Philippines, and he did his ophthalmology residency at the Department of Ophthalmology and Visual Sciences at UP-PGH. He subsequently did his ocular oncology fellowship and a separate fellowship in oculoplastic, lacrimal, and orbital surgery in Wills Eye Hospital in Philadelphia. He's the head of ocular oncology and orbital surgery in TMC, EVI, and is also the service chief of PLO in Manila Doctors Hospital. He continues to be a clinical associate professor at UP-PGH, where he heads the ocular oncology and retinoblastoma service. Hi, Dr. Mercado.
Sorry, I was on mute.
It's okay, sir.
Okay. Anyway, thank you, Pia, for the generous introduction, and I'd like to thank the TMC Eye Vision Institute for having us in this session of EyeTV. That was such a wonderful talk by Rian, and she really briefly went through the academic of eyelid tumors, and but I appreciate it so much that she talked about differential diagnosis and the clinical signs that lead us towards diagnosing between benign and malignant lesions. For today, we'd like to apply those pearls that Rian gave us by looking through a sample case. And I'm joined together with my oculoplastic colleagues at the TMC. Specifically, I'm joined by all of them. As a matter of fact, are graduates of the Medical City Ophthalmology program, but they have gone through fellowship training in different parts of the world. And I'm here to welcome Dr. Nonet Pasco Rosete. She was trained in Shiley Eye Institute, University of California in San Diego, with Dr. Don Kikawa, who's frequently attending our meetings here in Manila. And of course, we have Debbie Siapno, who had her fellowship at the Samsung Medical Center in Seoul, Korea, under Kim Yong-dok. And of course, lastly, but certainly not the least, I'm surrounded by very beautiful women, all oculoplastic surgeons, is Dr. Reg Valencia, who did her fellowship at with Kakisaki at the Aichi Medical University Hospital in Japan. So we will be discussing a case. We will be going through one case, and I hope we will be discussing it. We'll be asking questions to each other, and as the audience, I hope that you will come sit and listen to how oculoplastics surgeons think, pick up some pearls. Hopefully, we'll be able to reiterate what Rian went through during her lecture. So you'll see how we think and how we plan out surgery for eyelid lesions. So if you have questions, as the audience, please put them down in the chat box, and we will try to answer them at the end of the talk of Dr. Labunsad, which will immediately follow the case discussion. So without further ado, let's see the case. Yeah, there we go. So we have a 46-year-old female who presented with this right upper lid lesion. Is there anybody? Can anybody ask what? Is there any information you'd like to know? The history, maybe?
Hi, sir. I want to ask, when did the lesion start?
Okay. Well, the lesion started about a year ago. She said that it started off like a mongo-sized lump. And yeah, Reg, why are you asking about the duration? How does this help you?
Duration usually tells us a little bit about the nature of the lesion. So, if it appeared and if it's been there for quite some time and it's continually growing, we can suspect a neoplasm. On the other hand, an inflammatory or infectious process usually resolves with treatment or on its own.
Uh-huh. So this was seen a year ago and seems to be growing. So because she said initially it looked like a mongo-sized lesion. Now it's been a year and this is how it looked. So are you suspecting it's a neoplasm?
Yes, sir. I'm leaning towards a neoplasm.
Yeah. So if it's a neoplasm, is this benign or malignant?
Well, most malignant neoplasms grow rapidly, and this is actually a red flag, but there are still some malignant neoplasms that develop slowly. However, to determine whether it is benign or malignant, it still requires correlation with clinical findings.
Yeah, thanks, Reg. No, so that's a good point. So some tumors, although malignant tumors do grow fast, usually, some of them do grow slowly. Now, you mentioned about clinical findings, maybe correlating it with clinical findings, the history with the clinical findings, so that we get to know more. Can I venture? Can I venture to ask Debbie to describe what we're seeing here?
Okay, sure, sir. So in this picture, we see a yellowish nodule measuring around 4 to 5 millimeters located on your lid margin centrally with an erythematous area with telangiectasia medially to that nodule. But what's important to note here is that there is already a distortion of your lid margin and the loss of your eyelashes or madarosis, which I think these features would point out to a malignant process.
Okay, yeah. So we picked that up from Rian's lecture that sometimes when there is loss of architecture, loss of lashes, then we start considering malignancy. But allow me to play devil's advocate here. You mentioned earlier that there's this yellow spot in the middle. Could that yellow spot be oil deposits? Maybe it's a recurrent, like recurrent lesion, or maybe recurrent rhodiola. Could this be possible, which is a benign lesion?
Okay, sir. Well, certainly recurrent infections can actually distort or disrupt the architecture, no? But this would usually recover fully in time. In addition, we would want to also ask, no, in the history if there are previous surgeries or previous infections for the patient.
Right, right. So those are very important questions to ask. If you had surgery before, what kind of surgery? Did it totally resolve? Now, unfortunately, you weren't a good clinician. So the patient didn't have surgery by you and came back about 3, 4 months months later, and this is how she looks now. Then there you go.
Okay.
So can you describe this now for us, Deb?
Now we see here the new picture on your right. There's already this lesion with measuring maybe more than 10 millimeters in size with central ulceration and bleeding. And note that there is also that rolled up pigmented edges. And I think the most important feature here that we should note is there is already that disruption or the disruption of the normal lid architecture. And again, of course, your madarosis.
Right. So definitely there was change and it's growing. And now you see more of the disruption of the lid architecture. We're saying it again, the disruption of lid architecture, loss of the lashes, and I suppose you are really now thinking of something malignant.
Yes,
Yes,
sir,
Jen?
that's true.
And
Yeah.
based on the history and the clinical findings, can you venture to tell me what you think this kind of malignancy would be?
Well, yes, sir. Basing on our history and clinical findings, I would like to say it looks like a basal cell carcinoma.
And why is that then?
As previously mentioned or discussed, no, on our history, there was gradual progressive enlargement of the lesion. And on the clinical pictures, we note already that central ulceration with the rolled up edges and also some telangiectasia. And again, the red flags for your malignancy, your distortion of the lid architecture and the loss of your lashes.
Well, let me go back to that slowly growing. Slowly growing and it's still malignant?
Yes, sir. So as Reg mentioned, there might be some. It's not all of the lesions would be rapidly growing, but some lesions may also gradually progress in size.
And basal cell is one of those, right?
Yes, that's right, sir.
Now there's pigment that I can see there. You mentioned that earlier. It looks like it's pigmented. Could this be melanoma?
Well, it's always possible that the pigmentation could be indicative of melanoma. However, it's not uncommon, or it's more frequent to see pigmented BCC in patients with our skin tone and in our race.
Right. Okay. So I think we all agree that this probably is a, as you mentioned, the clinical findings appear to be neoplastic, appear to be malignant, and it seems to be basal cell carcinoma because one, the growth pattern is quite slow. It's not as rapid as other kinds of tumors. You do have the alteration of the lid architecture, specifically the loss of the eyelashes, and also the lid margins. If you see, it's eroded. So those are really features that this could be a malignant tumor, in particular a BCCA. Is there anything before we go to the management? Maybe is there any other comments for the diagnosis?
Actually, sir, yes. So at this point, I would like to stress the importance of lid eversion to all our colleagues. No? So this is something that we often miss out on doing, and this will give us a better picture of the lesion.
Oh, that's right. Deb, thanks for bringing that up. I almost missed that technique and that procedure that we do at the clinics. Could you kindly tell us why that would be necessary?
Okay, so sir, I'm actually quite guilty of that as well. So I sometimes forget doing the lid eversion, but it's very important to do it because flipping the eyelids will actually give us a more detailed idea as to the involvement of the structures underneath, no, particularly your posterior lamella. So sometimes, so we get to see patients who present to us with benign lesions, and if we don't invert the lids, we actually miss out on this diagnosis.
Right. You know, I've had a case before that it looked like, well, it's an elderly, but it looked like a chalasian. And when I flip the lid, you see the erosion on the other side. So that quickly tells you that it could be a sebaceous gland carcinoma instead of something benign. Other than that, you mentioned also that, of course, you will see the extent. So if there's more, sometimes the erosion is even more, or the invasion is even more posteriorly than it is anteriorly. So that's really something that we really need to do a lid version. Now, but you know, these are all clinical findings. We don't really know if this is truly malignant or this is really benign. Is there anything that we want to do? Nonet, maybe you want to give us.
Yeah, for this one, I think we have an option on whether to do an incision or excision biopsy.
Aha. Okay, and I agree. A biopsy would definitely tell us if this is malignant or benign, and maybe tell us what it is. You know? So, can you tell us something about the incision biopsy? What benefit it would do?
Well, as for me, well, I might do an incision biopsy first. Why, no? So it would give me an advantage of the histopathology early on. So know the enemy early on because 50% of the battle is done pagka alam mo na kung sinong kalaban mo. So know the enemy early, whether it's benign or malignant, and if it's indeed malignant, if it's aggressive or non-aggressive, as you have mentioned, because this would, knowing whether it's malignant or benign, aggressive or not aggressive, would dictate on how I would do my excision or surgical planning later on.
Yeah, that's right. So that helps us both in diagnosis and in treatment planning.
Mm-hmm.
That's right.
Yeah.
Huh? So yeah.
Yes.
So do you do?
Probably for this one, yeah. So I would proceed with the incisional biopsy. As we talked about it, as I mentioned, the aggressiveness of the particular tumor would be pivotal in whatever maneuvers or whatever surgical decisions I would later pursue.
So like in this case, we were thinking maybe this is a basal cell carcinoma. Would it change? How will it change in terms of a biopsy? How will it change your approach?
So, say, as I said, know the enemy. So,
Right.
if I were given a basal cell carcinoma, I would probably relax a bit and give it a what? A 4 millimeter margin incision, excision on outside of the lesion. But if I were dealing with a sebaceous cell carcinoma, that would probably give me about, I would probably give it about 5 to 6 millimeters lid margin from there because I'm dealing with a more aggressive enemy. The idea is to be able to get a good amount of normal tissue outside of the abnormal one because that would ensure that I was able to remove the lesion in itself. That would not only give me a good sleeping time, kasi it would tell me that my recurrence rate would probably be less, but it also give me an insight on how to plan this its surgical repair later on.
Right. So from the clinical standpoint, when you see the patient, you got to use your, fund of knowledge and determine whether you think this is what kind of a tumor, but still be confirmed by a biopsy, as what you were saying, so that we know how much of a margin we will do. It's quite devastating maybe for the patient when they, you take up a large piece of the eyelid and it turns out to be benign. And it's good for preparation when we do an incision biopsy, so we can plan out and discuss how much surgery we need to do and consequently how much repair. But bringing down to real world situation, especially in our situation, are there any particular situations where you find that incision biopsy sometimes is difficult to do?
Sir, sorry.
Yeah,
Yeah, I'd like to answer that. So I see a lot of patients who are not so well off. So I guess Doc Nonet is right. So it's in an ideal setting, you should do an incisional biopsy to know the enemy, to know what to do, and to have a better preparation. But sometimes, no, your situation is not ideal, and you get to have patients who have some financial or under financial constraints. So for these patients, you can probably give an option of excision biopsy. However, especially for this lesion, which is quite large, and if you don't know your histopath report, you might have to excise a little bigger or have to have a wide margin for these lesions. And then these wide margins will give you a larger defect to work with. So although this can be more challenging, no? If we assume kasi that the tumor is malignant and we do already your excision biopsy with wide margins, you're left with that big defect. You're right. What if it happens that the histopath comes out and it's benign? So technically, it's still ideal to do your incision biopsy, but sometimes you're left to do the excision biopsy. So if you do you have your reports already, you can actually present to the patient the best treatment options.
Right, right. So sometimes, I mean, I go to a lot of provinces when I do surgery, and a lot of them really have a hard time going to a doctor, and they really just want to get it out. They can't afford to both time and money to come back for a second surgery after the incision biopsy and wait. So yes, that is an option, but we have to go ideal, and the ideal way is really to do an incision biopsy and to do planning. Now, if it turns out malignant, really, and we know, for example, say it's basal, this is basal cell CA, what kind of margins do you want to achieve? I think we briefly discussed that with Nonet, but let's go back to it a little bit. Can I ask Reg? Reg, can you comment on that?
Yeah, sir. Generally, for BCCA, we usually do a 2 to 4 millimeter margin. For this case, I'd probably go for a 3 millimeter margin plus maybe 1 millimeter for the frozen section. So this would be a total of 4 millimeters. Of course, for squamous cell carcinoma, it's usually 3 to 5 millimeters, and for sebaceous gland carcinoma, it's 4 to 6 millimeters.
Why again? Why again the difference of
Yeah,
doing margins?
so as previously mentioned by Dr. Nonet, so these different malignancies vary in aggressiveness. So basal cell is less aggressive, followed by squamous cell carcinoma. Sebaceous gland carcinoma is very aggressive, hence the wide margin.
And you mentioned a good point there about frozen section control.
Yes.
Can you explain a little bit about frozen section and what the benefits are and why we need to do that most of the time?
Yeah, so frozen section involves getting pieces from around the margin, sending it for histopathological analysis. So this is to make sure that your margins are tumor free. So we usually do this intraoperatively, and we wait for the result before we do our reconstruction.
All right. Yeah. So it's really to make sure that we've taken out all the tumor and reduce the chances, the risk of recurrence for any kind of eyelid tumor, particularly, of course, for malignant eyelid tumors. So yeah. So for this patient, if we're thinking about this being basal cell carcinoma, we would do about, as you said, about 2 to 4 millimeters, and we'll move on to the procedure. And I think we have another slide here showing, um, yeah. So this is actually what we have after the dissection. You see how small the tumor is initially, and now this is what we are left with after we remove it. Can somebody describe the and tell us what's lacking? By the way, the green stuff there is a scleral shell. You're not seeing the cornea. It's a cover protecting the eye. So yeah, if somebody can describe what we're missing.
Yeah, I'll do that for you. We have a full thickness lid defect, meaning both your anterior and posterior lamellae are missing. Your anterior lamellae would pertain to your skin and your orbicularis, and the posterior lamellae is also missing. That's the tarsus and the conjunctiva.
Well, certainly we need to repair this, because then your eye is exposed and it's going to dry up. And of course, that's going to be a problem. The simplest way is, of course, to directly close it. But do you think we can directly close this, Nonet?
Definitely. Well, you tell me, sir. Well, but of course, direct closure is dependent on redundant tissues, and we see that we hardly see any tissue around. So based on this, my first option would be what? First, assess what we are missing. So as we said, we are missing both the anterior and posterior lamellae. We estimate the amount of deficient tissue depending on the lid length. So usually we do it on thirds. So 1/3, 2/3, we have a gamut of, arsenal of things to do. So for this case, I think it's about what, 70-80% missing. So for this, we have an option of doing either moving the skin and the other tissues around. That would be about using an anterior or lamellar graft. That would mean moving a tissue with a blood supply, or getting a free graft either for the tarsus or for the skin. So the idea is to replace both the anterior and the posterior. Important here would be the important traditional dictum is that we cannot put two grafts together because one should have an adequate blood supply or a stable blood supply. But I think Ken will present us later on that would, counter that traditional thought.
Yeah. Okay. Yeah. So just to remind everybody, as you all know, we have to repair all the other all the structures. And again, as what Rian mentioned earlier, the eyelid is composed of both anterior and posterior lamellae. We can't just cover the anterior lamellae by moving skin without replacing the um, posterior lamellae and have a smooth surface that touches the cornea. So we really have to replace all of these structures. Now, I think we have another photo, if it's still available. Yeah. So this is one of the traditional ways of repairing this. This is a Cutler beard procedure. So it's a lid sharing procedure. And as you can see, the, a full thickness eyelid is migrated from the inferior and shared into the superior eyelid with the defect. Once that's taken on, of course, this has a good blood supply from the inferior, and then once that's taken on, it will require a second surgery to disengage it and then repair. It's a nice procedure, but it requires two procedures. One to place it in, and then the other to release it. So this is one of the ways in plastic surgery, in oculoplastic surgery. There are many ways to treat things. We destroy them and then we repair them. So, but there are many ways of doing this, and I think it's about time we ask Ken to talk about management. I'm excited to see how he managed this particular case. He has a very novel way of having done this case. So let's hear it for Ken. I think Pia will introduce Ken now. Thank you, everybody, for joining me.
Hi. Thank you, everyone. Thank you, Dr. Mercado, and to all our consultants for that very fruitful discussion. I definitely learned a lot. But before we proceed to Dr. Lagunzad's lecture, let us first have a short break. All right. So I hope everyone is still tuned in. Again, if you have any questions for our speakers or any of our consultants, please type them in the comment section below. And of course, kindly fill out the attendance link, which will be sent later on. So, as was mentioned in the discussion earlier, there are techniques in order to repair the lid lesions that have been excised. So, to discuss the techniques in repairing eyelid defects, we have Dr. John Kenneth Lagunzad. Dr. Lagunzad finished medicine at the University of the East Ramon Magsaysay Memorial Medical Center and then proceeded to do his residency at the Department of Ophthalmology and Visual Sciences at UP-PGH. Subsequently, he did his fellowship training in ophthalmic, plastic, reconstructive, orbit, and lacrimal surgery training at the University of Hawaii John A. Burns School of Medicine. Dr. Lagunzad is currently the chief of ophthalmic, plastic, and lacrimal section of the TMC Eye and Vision Institute. He's also a clinical associate professor at the UP College of Medicine and is currently an active consultant at the Department of Ophthalmology and Visual Sciences of UP-PGH, as well as the Legazpi Eye Center in Legazpi, Albay. The floor is now yours, sir.
Thank you, Pia. Thank you, Dr. Texon, for the introduction. And thank you also to the TMC Eye Vision Institute for inviting us today for the episode of this EyeTV. Can I share my slides? Can everyone see my slides? Can you see my slides, Pia?
Hi,
Okay.
sir. Yes, sir. You can see your slides. You can press.
Can I begin?
Yes, you can
Can I
press
begin?
play presentation.
Okay. Okay. So, good evening, everyone. Marhay na banggi sa Indogabos to all my colleagues in Legazpi Albay. Tonight, I'll be talking about the principles of eyelid tumor excision and eyelid reconstruction. In this talk, I aim to discuss how to plan an excision of a malignant eyelid tumor. And I'll also discuss how to plan reconstruction of the eyelid defect after excision. And I will explain the rationale of the steps in eyelid reconstruction. To achieve these goals, I will discuss the most common malignancies involved in the eyelid and the techniques done to ensure its complete excision. I will also talk about the available options of eyelid reconstruction based on the size and location of the eyelid defect. And finally, I will show the reconstructive technique done in the case presented earlier and explain the rationale of each step.
Sir,
I will try to discuss these topics.
sir, sorry, sir. It's not on. Can you please press your slideshow? It's your presenter notes, I think.
Sorry. How do I do that?
The button on the lower right, sir.
Hmm.
There, that one, sir.
Is that good?
Not yet, sir. Hold on, sir. I'll call on the technical team to help us, sir.
Okay, no worries.
Sorry, everyone. Just give us a few seconds to deal with the technical difficulties.
Is that okay? Just let me know.
Oh, sir, can you try to reshare your screen? Stop sharing and then reshare.
Okay. I stop sharing.
Yes, and then
Let me
reshare.
share. No worries. Applications window, select share.
And then try to press.
Is that okay?
Oh, no, not yet, sir. Hold on, sir. Go to the slideshow on top, sir. And then press there. Then press play screen. The leftmost, sir.
What?
That one, sir. Play screen. Play from start, sir. That's the one.
Yeah, play from start.
Yes. It's not. Hold on, sir. Hold on, sir. You can try to stop sharing. To press stop sharing first.
Okay.
Just fix this one, sir. Hold on.
Sure.
ngayon, iba na. Ang karaniwang araw ng bawat Juan, Pedro at Maria ay makipagkita na lang sa internet. Pero paano kung biglaang magkasakit si Pedro? Nangangati, may mga butlig at unti-unti nang di makakita. Ano na ang gagawin? Maaaring mayroon ng tinatawag na shingles o kulebra si Pedro. Maliban sa katawan, pwede itong makaapekto sa mukha at mata. Paano nga ba nagkakaroon ng kulebra? Ito ay isang sakit na nadudulot ng isang virus. Itong virus rin ang sanhi ng chickenpox o bulutong tubig sa mga bata. Maski gumaling na ang bulutong tubig, ang virus ay nananatili sa mga ugat o nerves. Sa pag-edad at pagkakasakit, maaaring magising muli ang virus at magdulot na naman ng sakit na tinatawag na shingles o kulebra. Hindi ito tulad ng bulutong tubig na nakikita sa buong katawan. Ang pananakit at putlig-putlig ng kulebra ay nakikita lamang sa isang parte ng katawan. Kapag ang isang tao ay nagkaroon ng kulebra sa may parte ng muka, ay pwede nitong maapektuhan ang ating mata o ang tinatawag na herpes zoster ophthalmicus. Maliban sa mga butlig sa muka, maaaring magkaroon ng lagnat, pananakit ng ulo at mata, pagluluha, pamamaga ng talukap ng mata, at pagiging sensitibo sa ilaw. Sa mga ganitong pagkakataon, maaari nang magsuspetsya ng herpes zoster ophthalmicus. Ano ang iyong gagawin kung may herpes zoster ophthalmicus ka nga? Mainam na kumonsulta agad sa iyong doktor o sa isang espesyalista sa mata upang maagapan ang potensyal na pinsala sa cornea. Ang HZO ay ginagamot gamit ang antivirals. Ang mga ito ay pumupuksa sa mga virus na nagdudulot ng HZO. Maaari rin mabigyan ng steroid para sa mata upang malunasan ang inflammation o pamamaga. Nakakahawa ang kulebra, kaya dapat maagapan ito ng maaga. Mahalagang ma-diagnose ng maaga ang impeksyon upang mapigilan ang pagtuloy nito sa HZO. Mas maganda kung maiwasan ang impeksyon sa pamamagitan ng bakuna laban sa varicella zoster virus. Ginagamit din ang varicella immunoglobulin upang maiwasan ang mga epekto nito kung na-expose sa taong may aktibong infeksyon.
Can you see it? Yeah, can you see it? Okay. Okay. Sorry for that technical difficulty. I will start again with the objectives of my talk. So now, my aim in this talk is to discuss how to plan an excision of a malignant eyelid tumor, okay, and to discuss how to plan the reconstruction of the eyelid defect after the excision, okay, and explain the rationale of the steps in eyelid reconstruction. So to achieve these goals, I will discuss the most common malignancies involved in the eyelid and the techniques done to ensure its complete excision. I will also talk about the available options of eyelid reconstruction based on the size and location of the eyelid defect. And finally, I will show the reconstructive technique done in the case presented earlier and explain the rationale of each step. I will try to discuss these topics as straightforward as I can because, as Albert Einstein said, science must be simple to be useful. A study by the Philippine Eye Research Institute over a 10-year period found that the basal cell carcinoma and sebaceous gland carcinoma were the most common eyelid malignancies. Squamous cell carcinoma and melanoma and lymphoma completed the top 5. When I get referrals from a colleague to evaluate a suspicious eyelid lesion, these are the questions that I ask myself when I'm examining the patient. Is this lesion malignant? If this lesion is malignant, what kind of tumor is it and how aggressive can it be? What is the extent of the tumor? If I plan to remove it, how wide will my excision be? How can I be sure that I have completely excised the tumor? What tissues will be lost after excision? And how will I be able to reconstruct it to return the function and appearance of the eyelid? So to answer the first question, is this malignant? Knowing the history, signs and symptoms, and predisposing factors will help us differentiate it from benign lesions. We rely highly on our clinical experience to identify these malignant tumors, the basis of which were thoroughly discussed earlier by Dr. Parulan. Now, the difference between excising a benign and malignant tumor is that in malignant tumors, a wider excision is required in order to ensure complete excision of the potentially devastating disease. That being said, the wider the excision, the wider the resulting defect, and the more challenging the reconstruction. In the focused physical examination of the eyelid mass, signs like ulceration, induration, irregular borders, destruction of eyelid architecture, madarosis or loss of lashes, telangiectasia, pearly borders should alert the ophthalmologist, and malignancy should highly be considered. I like to emphasize that all these characteristics of malignancy are not always seen in each tumor. It is already sufficient to suspect malignancy when at least one characteristic is present. If you reach this point that you are highly considering malignancy, the next thing you'll ask yourself is, what kind of tumor is it and how aggressive can it be? This will really be based on your clinical experience, as Dr. Parulan has showed a lot of images that distinguishes these common malignant tumors from one another. Now, this table shows the most common lead tumors and how they spread. So you can see that basal cell carcinoma and squamous cell carcinoma are locally invasive and they rarely metastasize. However, sebaceous gland carcinoma and melanoma are highly malignant and are capable of distant metastasis. The principles of excising a tumor is similar whether you're excising a small or a large mass. The main goal is still complete excision. The significant difference between the two will be the reconstruction of the defect. So the first question in my head will be, how wide will my excision be? I base this decision on its extent and histopathology. Your focused physical examination will really help in establishing the extent of the tumor. What are the dimensions of the tumor? Measure the lesion in 3 dimensions with the length, the width, and the height. Include not only the obvious pigmented part, but also the indurated area with madarosis or lost lashes. What structures of the lid are involved? Does it involve the anterior lamellae, the skin and the orbicularis muscle, or the posterior lamellae, which includes the tarsus and the conjunctiva, or both, meaning it's a full thickness lid involvement? That is why we emphasize to our colleagues the importance of everting the eyelids. Does this involve the margin? If it does, note the extent of involvement. Does it involve the lash line, the gray line, the meibomian line, the mucocutaneous junction, and even the conjunctiva? Are the canthal areas involved? If medial canthal areas are involved, there are 2 concerns. It may destroy the tear drainage and an avenue for tumor spread. If the lateral canthal area is involved, it may involve both upper and lower eyelids, and it is more challenging to repair. Does it involve more posterior structures like the orbit? Clinically, we suspect this if the mass is non-movable and it's attached to deeper tissues like the periosteum around the orbital rim. We also note of orbital signs like proptosis, limited extraocular movement, and resistance to retropulsion of the eye. An orbital sign would warrant an orbital CT scan prior to management of the lid mass. Check also, has it spread to the lymph nodes? Always palpate for preauricular, submandibular, or cervical lymph nodes to rule out extension to the regional lymph nodes. If it's positive, you have to refer also the patient to an ENT specialist for biopsy of these nodes. A pet peeve of mine, and I always emphasize to the residents, is always check for the visual acuity of both eyes, especially the other eye without the eyelid lesion. The significance of this is, during reconstruction, the use of large bridging flaps from the upper to the lower lid and vice versa, as well as temporary tarsorrhaphies, will, will occlude the patient's vision on the side that you will be working on. My point being, if the vision on the contralateral eye is poor, for example, because of a cataract, you have to perform the cataract surgery first before carrying out the lid surgery. Now, how will you decide also will also be based on the histopathology. During the discussion, they extensively talked about performing an incision biopsy. The advantages of doing an incision biopsy is that it confirms your clinical suspicion of malignancy. And it also helps you decide the size of the excision because more aggressive tumors require wider excisions. Incisional biopsy is a type of biopsy in which a sample of suspicious tissue is cut from the mass and removed for purposes of diagnosis. It is indicated when your clinical diagnosis is in doubt and when extensive reconstruction is being considered. It confirms your diagnosis and can serve as a guide on what type of malignancy you're dealing with before excising the entire tumor. The disadvantage of incision biopsy is that when too little tissue was taken, or when the specimen is crushed during collection, or when it was taken in less ideal places, the diagnosis may be missed. In order to ensure accurate diagnosis, the specimen obtained from the incisional biopsy should be adequate in size for histopathologic processing. It is best to obtain a sample at the periphery of the lesion. The center of the lesion should not be sampled, especially if there is a central ulceration, because histopathologic interpretation may yield only necrotic tissues. The sample should contain normal tissue at the margin to show the transitional area. Now, based on the biopsy result you got, these are the recommended surgical margins for the following common malignant eyelid tumors. As you can see, basal cell carcinoma and squamous cell carcinoma, which are not metastasizing commonly and are locally invasive, have smaller margins compared to the more malignant, more aggressive sebaceous gland carcinoma and malignant melanoma, which requires the largest excision for the margins. This is an example of a 7 by 7 millimeter sebaceous gland carcinoma that ended up with a 17 by 12 lid defect. This demonstrates that even the tumor that was relatively small warranted a larger margin for excision due to the aggressiveness of sebaceous cell carcinoma. Once the diagnosis of malignant eyelid tumor is confirmed from incisional biopsy, excisional biopsy is performed. The surgical aim should be to completely excise the tumor with adequate margin clearance to minimize recurrence or metastasis. Since microscopic margin is often considered to extend beyond the macroscopic margin, how can I be sure that I have completely excised the tumor? We need to have a histologic monitoring of the tumor borders to ensure complete excision. Two techniques are currently accepted methods for surgical removal of eyelid malignancies. These are the Mohs micrographic surgery and frozen section control using microscopic evaluations of the margins. Mohs excision offers the most precise form of skin tumor removal with conservation of tissue that in the eyelid area is very important. The most common doctors trained to perform Mohs micrographic surgery are dermatologists. The tumor is excised in small lamellar tissue blocks and is histologically examined. If the tumor is still present, additional lamellar blocks are excised until all of the malignancy has been removed. This is ideal for infiltrating tumors with no definite edge that is almost impossible to outline the margins accurately. The advantage of most technique using serial shave excisions is that the tumor is viewed in horizontal sections, which show infiltration of the tumor towards the specimen edge more clearly than the common vertical sections. The disadvantage is that the surgeon, or in this case the dermatologist performing the excision, does not perform the reconstruction. Since excision and reconstruction is staged, it will take a little bit longer and it will cost more. Now we're going to talk about the frozen section. The frozen section is a pathological procedure to perform rapid microscopic analysis of the specimen. It is sensitive and specific for detecting malignant cells and providing margin clearance. During this intraoperative consultation, the entire peripheral margins are submitted systematically and labeled. The main purpose of the pathologist is to inform the surgeon if the resection margin is clear of residual tumors. If residual cancer is present, the surgeon will re-excise additional tissue of the specified margin. When all margins are negative, reconstruction of the eyelid can now proceed. In the permanent section process, the tissue is treated by a series of chemical solutions that give a high quality slide. The advantage of this process is that it is more accurate and allows the pathologist to make a more correct diagnosis. So even if frozen section was performed, all specimens are sent for permanent section. So let's go back to the case that was presented during the discussion. This is a 46-year-old female who came for a right upper lid mass. Now we answer this: is this lesion malignant? I would have to agree with the panel, right? I think it looks malignant based on the history of enlarging mass and the physical findings of madarosis, central ulceration, and destruction of lid margin architecture. These findings indeed point to a malignancy. If it is malignant, what kind of tumor is it and how aggressive can it be? According to the panel, clinically it looks like a basal cell carcinoma, the basis of which are it's pigmented, it's indurated with central ulcer, and with rolled up edges. How aggressive? We know that BCC or basal cell carcinoma are locally invasive and rarely metastasize. Now the question that will be asked is, what's the extent of the tumor? I actually performed the measurements and it was actually 18 by 5 by 5 millimeters. It involved the lid margin, the medial canthus, the anterior and posterior lamella, the upper punctum, but this did not involve the deeper structures like the orbit, and I was not able to palpate any enlarged preauricular and submandibular lymph nodes. And the visual acuity for the patient is 20/20 for both eyes. Incision biopsy done previously prior to the consult indeed revealed basal cell carcinoma. So the suggested margins for excision is 2 to 4 millimeters. The plan is to do wide excision with a total of 26 by 9 millimeters full thickness due to a 3 millimeter plus 1 millimeter margin for frozen section. How to make sure tumor is completely excised in this case? We do a frozen section. Okay, so here we mark the significant margins of the tumor with a surgical marker. We highlighted the yellow dotted line to mark the tumor edge we made around the macroscopic tumor margin. Here, the red dotted lines correspond to the margin of the excision, which is exactly 3 millimeters from the margin of the macroscopic tumor. We based this from the incision biopsy done that turned out to be basal cell carcinoma. Here, the blue dotted lines correspond to the margin of tissue that was sent for frozen section. So the tissue from the lid margin to the red line will be excised and sent for permanent section. This is fixed in formalin and will be read by the pathologist, and the results will come out after a few days to a week, while the outermost 1 millimeter edge marked by the blue dotted line will be sent for frozen section and will be read by the pathologist to monitor the tumor margins. This will take about an hour, and the results will be relayed to the operating room. While anxiously waiting for the hopefully negative tumor margins, the team of surgeons were already preparing for the steps to take for lid reconstruction, like preparing the donor site. In this case, skin grafts were needed. This image demonstrates the eversion of the upper eyelid, which was emphasized earlier. Pointed by the yellow arrow is a 3 by 3 millimeter smooth pigmented well-delineated lesion in the palpebral conjunctiva that is 1 millimeter from the lid margin and is 5 millimeters from the medial canthus. Pointed by the white arrow is an adjacent lesion with the same characteristics. However, it's located on the meibomian gland line of the lid margin and is 3 millimeters from the medial canthus. The purple lines noted on the superior tarsal border on the conjunctival side are just markings made by the surgical marker. These are the dimensions for excision with a minimum of the length of 26 millimeters in length, 9 millimeter in height, and the width will be full thickness, anterior posterior. It is important to know what tissues will be excised so we can plan the structures that we're going to replace. I think this is the perfect time to briefly discuss the anatomy in order to better understand the principles of this reconstruction. These are sagittal illustrations of the upper eyelid on the left picture and the lower eyelid on the right. The upper and the lower eyelid have analogous structures. However, you will notice that the structures on the upper lid is taller compared to the lower lid. This is mainly because the upper lid is responsible for blinking and spreading the tear film. And because of this, the upper eyelid is generally more challenging to reconstruct. When planning reconstruction, we must prepare the tissues by layers in order to restore its form and function. We approach this by dividing the eyelid into an anterior and posterior lamella. And at the level of the lid margin, the anterior lamella is composed of the skin and the orbicularis muscle, while the posterior lamella is composed of the tarsal plate and the conjunctiva. Aside from anatomical structures, we should also be familiar with the topographic measurements of the eyelid. We refer to this as eyelid vital signs. So normally, the marginal reflex distance 1, which is the distance from the Hirschberg reflex to the upper lid margin, is 4 millimeters. And the marginal reflex distance 2, which is the distance from the reflex to the lower lid margin, is 5 millimeters. So the vertical palpebral fissure should be the sum of the two, and it is 9. While the horizontal fissure is normally at 30 millimeters. Notice also I measured the lid crease height, and normally it's 3 millimeters for Asians. There's also a notable distance from the lid crease height to the eyebrow, and it's normally 10 millimeters. So quick tips on eyelid position. The upper eyelid margin lies 1 to 2 millimeters below the corneal limbus, the upper corneal limbus. The lower lid margin is at the level of the lower corneal limbus. The vertical palpebral fissure measures 9 to 10 millimeters. The upper lid peak lies just nasal to the center of the pupil. And in Asian eyelids, the upper lid crease is 3 to 4 millimeters above the margin. And the lateral angle between the two lids is about 2 millimeters higher than the rounded medial angle. So these things are very important, not only the structures, but its position when you're actually repairing the patient. So proper eyelid closure and normal blink reflexes are essentially, it's very important, no? So because it takes care of the ocular surface and the tear film. So it's important to test this function prior to any eyelid surgery. So check if there is lagophthalmos or incomplete eyelid closure prior to surgery. So keep a mental note that the procedure can make this condition even worse. So prime the patient if you think that the risk is high, but there are surgical techniques to lessen this. This test evaluates the ability of the levator muscle to retract and lift the upper eyelid, and it's called the levator function test. Keep a mental note that the procedure can make this condition even worse. And prime the patient if you think, for example, if you're going to excise a part of the levator muscle, then you would expect drooping or ptosis on the patient postoperatively. So going back to the case, this is an appraisal of the defect in terms of location, tissue involved, and the size. So we have an upper eyelid tumor that is margin involving that affected both the anterior and posterior lamella, including the punctum on the upper lid, that measures 18 by 5 by 5 millimeters. Previous biopsy revealed basal cell carcinoma, so we elected to do a full thickness excision with a 3 millimeter margin plus an additional 1 millimeter for the frozen section, and this leaves us with a 26 by 9 millimeter defect. This is the summary of the defect after excision. After full analysis of the abnormality, we can now form a strategy for reconstruction. The strategy has only one goal, and it is a function and the goal with to restore the function and appearance as normal as possible. The following general principles are followed in eyelid reconstruction. We have to reconstruct only either the anterior or the posterior lamella with a graft. Both the anterior and posterior lamella should not be reconstructed with a graft. One of the layers must provide blood supply, and the graft placed on the graft has a high likelihood of failure. Maximize horizontal tension and minimize vertical tension. Maintain anatomical canthal fixation and match like tissues to like tissues. Narrow the defect as much as possible before sizing the graft. These are the goals of the reconstruction. You have to have a stable eyelid margin, an adequate vertical eyelid height, adequate eyelid closure, smooth internal surface, and maximum cosmesis and symmetry. A correct inventory and analysis of the abnormalities that are present is of utmost importance in order to choose the best procedure to correct it. This means a complete analysis of the resultant tissue defect must be made before considering what to do next. Although a bit busy, I like this slide because it shows you at a glance the simplest options for reconstruction based on the size and location of the eyelid defect. On the left column, it shows the lower eyelid defects, and on the right column shows the upper lid defects. And as you go down the column, it shows increasing size of the defect, and the highlighted side notes are the suggested techniques on how to repair it. So the eyelid defects that are less than 33% can be repaired by primary closure. The photo on the left shows a lower lid defect that is caused by full thickness excision. This principle of repair is applicable to the upper eyelid as well. So primary closure with this size is applicable to the lower lid and the upper lid. Now here, if there's too much tension when you try to do that primary closure, you may try to choose the eyelids. You can do a lateral cantotomy and cantholysis to advance the adjacent tissues. And this decreases the tension on your lid margin closure. On a bigger defect, sizing 33 to 50%, a tensile semicircular flap can be used to repair it. In the tensile semicircular flap, the lateral canthal tendon is incised and a semicircular myocutaneous advancement flap is made below the lateral portion of the eyebrow to allow further mobilization of the eyelid, as you can see in the picture. So in the end, after you have achieved satisfactory mobilization of the tissue, anchor the flap medially on the lateral canthal periosteum, and lastly do the primary closure. So, in cases where more than 50% of the eyelid has been excised, the resulting defect is too large that advancement of adjacent tissues alone might not be sufficient. That's why we make use of flaps and grafts. And it is important to be familiar uh, to the possible sources of these tissues. So here, posterior lamellar defects can be replaced by using tarsoconjunctival flap or graft using either a free tarsal graft from the contralateral upper eyelid, hard palate mucosa, sclera, ear cartilage, or nasal septal cartilage. The entire thickness of the epidermis and dermis has been removed in full thickness skin grafts from donor site for transfer to the eyelid. So these are the possible sources of skin grafts. No? The contralateral upper eyelid, which is the best source because it's similar in color and thickness. You can also get from the pre and post auricular area. You can get from the supraclavicular area, which is one of my favorites because it's large. And you can also get from the inner arm if you have no more choice. So this is an example of lower eyelid reconstruction, more than 50% defect. This is called the Hughes procedure or the tarsoconjunctival flap with a full thickness skin graft. And it's used to reconstruct defects on the lower lid of more than 50% defect. The procedure uses a flap of tarsus and conjunctiva from the upper eyelid, which is sutured to the lower eyelid. And then a full thickness skin graft is sutured over the flap and serve as the anterior lamella. As you can see on the right lower picture, the skin has already has vascularized and it's color pink, and the skin sutures have been removed. So this is the picture on the left is still connecting the upper eyelid flap to the lower lid defect, but you can see that the skin has already been vascularized. So the usual time of release of this flap is usually, I tell the residents, 6 weeks, and that would be enough time for the skin graft to survive, as you can see on the right picture. So this is another technique. I have not personally done this, but this is called the Mustardi flap or the cheek rotational flap. It's an advancement flap used to repair the anterior lamella if there's a very large defect on the lower eyelid. But in this technique, replacement of the posterior lamellar defect is needed together with this flap. So you can use a free graft, like a free tarsal graft that you will harvest from a donor on the contralateral upper eyelid. And then you can swing and rotate the flap to close the defect. Now here, we've talked about this earlier. This is what you call the Cutler beard technique, where it is used to repair the upper eyelid defect that is more than 50%. You can see that the lower eyelid is being transferred to the upper eyelid, and that would close the defect that was left. Here was the picture presented earlier, and you can see that the tissue on the right has already taken up, and the vascularization is good, and the color of the skin is pink. But like Dr. Mercado said, this will require another stage procedure to open the bridge flap. So going back to the case, for an upper eyelid 50% defect, you have the choices of Cutler beard, but we also have a novel technique called the orbicularis sandwich technique. And we use a free tarsal graft, an orbicularis muscle advancement flap, and a full thickness skin graft. And this is what we chose. And the choice is really dependent on what the surgeon is comfortable doing. The use of an orbicularis oculi muscle flap between two free autologous grafts have not yet been widely reported, and actually only 3 or 4 journals have been published in this kind of technique. and we had several experience of this, and we were successful in our patients. This was taught to me by Dr. Franklin Kleiner, who started this procedure here in the Philippines, and we're very comfortable and happy to use this technique on this patient. So before beginning the repair, I'd like to remind or just to emphasize that the instruments used for excision are set aside and a new instrument set is used for reconstruction to avoid the spread of cancer cells in neighboring tissues. So we begin the reconstruction of the defect here by replacing the posterior lamellae with a graft. Okay, so tarsal conjunctival graft. So we chose to use a free tarsal graft with from the contralateral upper eyelid, and this is the donor side. And now you can see here that the donor tarsoconjunctival graft is laid on top of the exposed cornea, and this will serve as the new posterior lamella for the recipient side. Now here, we identified the levator aponeurosis and dissected it so we can isolate it and attached it to the tarsoconjunctival graft. Our intention is to recreate the connection of the levator aponeurosis to the anterior surface of the superior tarsal border so that the patient will have no problem lifting her new eyelid and won't have ptosis post-op. And then we sutured the levator aponeurosis to the tarsoconjunctival graft using Vicryl 6O with partial thickness bite to avoid the sutures from abrading the cornea. The medial edge of the graft is sutured to the medial canthal tissues, and at present, there is no technique that can restore an excised punctum. So that punctum was really sacrificed in order to prevent the spread of the tumor because it was part of the margin. And as we know, it's a connection to the lacrimal system, and it's an avenue for tumor spread. So it's okay to excise that. Anyway, the patient still has a lower punctum, and usually they will rarely complain of epiphora if there's another access of tears to the lacrimal drainage. Now we have now constructed the posterior lamellae, and however, the graft will not survive without a blood supply because this is a graft. So we dissected the orbicularis muscle on the superior eyelid and just below the brow area, and we directly transposed over the transconjunctival graft, as you can see. This created a bipedical flap, a similar technique to the Gunderson flap for the corneal specialist listening. This will serve as a source of blood supply for the posterior lamellar graft. So now you can see that the orbicularis flap was then sutured to the graft posteriorly using Vicryl 6O, again using partial thickness to avoid injuring the cornea. All is left now is the skin, and the anterior lamella will be complete. So it should have been, it would have been a good choice to transpose the skin from the upper lid if only the patient had redundant skin. However, the patient is relatively young, so that's not an option we took. So we decided to use skin graft since its bed will be the orbicularis flap, which also is rich in blood supply. So this is the choice that we chose. We chose this as the donor site. So since it's a large defect, we chose to harvest from the supraclavicular area. And since it's a good match to the eyelid skin color, texture, and thickness, this is a good choice. And this step was performed by a current fellow, Dr. Apia Texon. So you can see now that we closed the donor site at the supraclavicular area using Vicryl 6O, and we plan to remove it after 1 week. So here you can see that the skin graft was measured and trimmed and was laid over the suture, the orbicularis muscle, and sutured using a running silk 6O suture. And this step was done by our senior resident, Dr. Abby De Gia. The orbicularis muscle flap, which is the source of blood supply for the posterior tarsal graft and the anterior skin graft, is now sandwiched between them. This ensures the survival of both grafts, and the orbicularis sandwich technique allows for large defect reconstruction and maybe a one-stage alternative to the Cutler beard in selected cases. So we placed interrupted 6O sutures with long wicks that secured the bolster dressing. And we placed a temporary tarsorrhaphy to stretch out the skin graft and prevented it from moving. So this is the patient 1 week post-op, and the tarsorrhaphy is still intact, and the skin graft looks pink. So that's a good sign that it's vascularized from the orbicularis bed. So we wanted to keep the tarsorrhaphy longer to avoid contraction of the wound superiorly, and we took out the tarsorrhaphy 1 month after surgery. So this is the patient after tarsorrhaphy was removed. And you can see the height, the contour, the palpebral fissure. You can observe it. And this is a video, if I may share. I tested the movement of the patient. You can see that the blink is good. There is no lagophthalmos. Like she's just, I asked her to close her eyes like she's just sleeping. And then I asked her to move her eyelids and see if there's control in moving it individually. I asked her to look to the right, look to the left, and close her right eye and close her left eye. And I think we were able to successfully reconstruct the eyelid using this technique. So the advantage of this technique is that it's just a one-time surgery, unlike the Cutler beard, which is very famous in repairing the upper eyelid, large upper eyelid defects. Um, this one does not use a bridging flap that needs to be divided on a secondary surgery. So I think my take home message is the importance of clinical diagnosis. You have to do a good history and PE, and in your physical examination, you'll be able to know the extent of the tumor. It's important to invert the lids, check the lymph nodes, and check for orbital signs. So don't forget those things. I'd like to emphasize also the importance of incision biopsy to confirm the diagnosis and to guide you in the size of the margins that you will have to dissect. For reconstruction, know your defects, know your anatomy, and the principles of a successful reconstructive surgery would be to have a good blood supply and never do a graft on top of a graft, and also don't forget to follow up your patients closely and monitor tumor recurrence. So the follow-up is frequent when it's closer to the operative time, but it will be less frequent as years pass by. So that is my lecture. Thank you very much.
Thank you very much, Dr. Lagunzad. That perfectly complemented earlier's discussion and also further cemented all the points that were made during the discussion earlier. So those were all very interesting lectures from our speakers and an equally engaging case discussion. As a fellow, I definitely learned a lot tonight, and it was such a good review for me. I can only hope, and I hope that all our other viewers learned a lot as well and were able to take home valuable points. So I think we have a number of questions from our viewers. Let us go through each question. I would like to invite back to the screen all of our questions. Hello again, everyone.
Hi,
So,
Pia.
hi, hi. So we'll be starting our question and answer portion. We'll just wait for the questions to be posted. So that was a very good discussion, and I think we have a couple of questions regarding our discussion earlier. So for the first question, we have a patient with a pre-existing nevus since childhood on the upper lid, and a few months ago, she noted sudden enlargement in size accompanied by itchiness. Until when do I observe or request to do a biopsy? Um, Anyone can answer this question.
Okay, maybe for this, we just need to go back to the basics of identifying whether it is benign or malignant lesion. So it's not common actually for nevus to transform into a malignancy, but it is not impossible. So we just have to watch out for the warning signs mentioned earlier, such as asymmetry, irregular borders, any change in color, a sudden increase in size, ulceration or bleeding, or any destruction of the eyelid structure. So monitoring by taking photographs can actually help in observing for any changes. If such warning signs are seen, then it is indeed prudent to do a biopsy.
Okay, thank you for that, Dr. Yes, I agree that I think photos are very good for monitoring. I think like when you ask patients if they can show a photo previously, even if it's not taken by you, like an old photo, and then you can compare it will also help. Thank you for that, Dr.
Tia,
Um,
can I add something?
yes, sure, Doc.
Yeah. So I just want to add no. So sometimes these lesions evolve, diba? So that's one of the ABCDEs. So what you can do if you notice that change, you can ask the patient to come back earlier to you para you can monitor them more closely. So that's another way into parang being more prudent about taking care of these lesions. Kasi yun nga, it can turn out later on to become malignant.
That's right. Also, nevi are some nevi really enlarge, but if you follow what Rian mentioned, the ABCDE, then you can monitor it more properly. So it doesn't mean that since it's a nevus that you don't expect it to grow. It can actually grow, and usually they grow during the adolescent period.
Thank you for that, sir, and thank you also, Dr. Yan. Um, okay, if there's no other answers, we can go to the next question. Okay, so we have another short case consult. If a patient with recurrent hordeolum about 3 times already, and an INC was done twice on this patient, even if there is no loss of lashes or changes in the structure, would you suggest to still do a biopsy for this patient?
Uh, Pia, yeah. Hello, can you hear me?
Yes, Dr. Lee.
Okay. Yeah, I think Rian mentioned also a while ago in her lecture about the sebaceous gland carcinoma being a great mimicker. So usually it mimics conditions such as recurrent chalacia and sometimes even those recalcitrant unilateral blepharoconjunctivitis. No? So for these patients with recurrent hordeolum, wherein you have done your surgical treatment several times already, you should also take note if there's resolution of those lumps, or if there's also persistence, no, even after the treatment. But I think this could warrant already biopsy for the patient.
Can I add something?
Sure.
Sorry, yeah. Free flowing. I would also want to know the age of the patient,
Yeah, that's right.
right? So if the patient is very young, it's probably not like it's like a child. I would probably observe it a little bit more longer. But if the patient is already like a senior citizen, I wouldn't hesitate to do a biopsy.
That's true. That's true.
That's all.
Thank you for that
Oh,
also.
for the first case, I thought of something. The lid mass that was he thought was a nevus. Sometimes patients, we would think that we're trying to, of course, primarily rule out malignancy, but sometimes they really come for just aesthetic reasons. Eh. They don't want it in their eyelid. So if you're going to do, if it's suspicious, you can do an incision. But if it looks like a nevus and it's benign, um, double benefit. Mas maganda pa siya. Just a thought.
Okay, thank you, sir. I think those first two questions were very nice because they're actually lesions or things that I think a lot of ophthalmologists see quite frequently in their clinic. So a nevus or a mole, and also the a recurrent hordeolum or style. Okay. Do we have another question? I think we have another one. Okay. So the third question is: do you suggest to still get an orbital CT scan in a patient with a lid lesion, but with no signs of orbital involvement on examination?
Can I
No.
answer that, Tia? Can I try to
Okay.
answer?
Yeah, sure.
Okay. Actually, yeah, actually, for me, that case is very gray area. It really depends no, on what kind of lesion presents to you. So usually, if small and localized, even if it's already proven that it's malignant, but you know that the nature of this lesion is locally invasive and slow growing, you can actually rely more on your clinical assessment. If there's no involvement of the orbit, you can actually just make sure that you palpate well, because sometimes there are lesions that's underneath the skin and it actually hides, no, so you only see the surface pero underneath it's bigger. So as long as you're sure about your clinical examination and it's purely on the eyelid, you can do away with a CT. But it's different if a patient comes to you with a recurrent lesion and it's previously malignant and then it recurred again and then you palpate it's slightly bigger, then I might think twice of maybe doing a CT scan or an imaging. I don't know for the other consultants. Maybe.
Does anybody want to add to that?
Sir Gary.
Well,
Sir Gary.
it's really your clinical examination that's very necessary, and the location of the tumor. So if we're talking about eyelid tumors and it's in the medial area, like the medial canthal area, then you'll be a bit more cautious. But of course, if it's in the central eyelid, then you'll know the extent clearly by clinical exam. You pointed out there that you do a good orbital exam, those tests that you check whether there's any affectation of tissues of the orbit. Then clearly, I think it's not very necessary to do a CT scan of the orbit. Yeah.
Thank you, Dr. Yan and Dr. Mercado. Yes, I think, yeah, that's why going back again, as we're always taught to always do a very good physical examination, so you sort of can tell if there's an orbital involvement. You can do.
If you don't mind, yeah, no, going back, sorry, I apologize if I have to go back to that second case where that's always, I always get a referral from a general ophthalmologist when they get recurrences from their INC. And that point that Ken post saying that, depends, you got to get the history well. You don't normally get sebaceous gland carcinoma from the young age group. If there's a high risk for chelation anyway, and of course, when you do your INC, if you're able to drain something, then you shouldn't be too worried. Maybe you just didn't get enough. So it keeps coming back. No? So you have to deal with all these things. You have to make sure that their tear glands, their oil glands are also good. So you have to take care of that. So don't panic. I know that when we read our textbooks, that is what sticks to us. If it's a chelation that keeps coming back, they're thinking malignant. But hey, sending the tissue for biopsy, that's not a big problem anyway. So if you're really afraid, you can err on getting the biopsy anyway.
I agree.
Whatever makes you sleep better at night.
That's right. That's right.
Yeah.
No, but having said that, I had my Manila doctors. I had 72-year-old patient came up with like a thumb size lesion there on the lid. So I was bragging to them that yeah, we can do we need to do a biopsy. This is definitely a sebaceous gland carcinoma. Did it in the clinic. I used my grade 11 and I punctured it. Everything came out. All this pus came out, black pus. He's been keeping that for years. It turned out to be a chelation, not on a 72-year-old. So
So
can be
as long
wrong.
as you can, yes. So as long as you can get something out of the lesion, then it
Yep.
might be.
Yeah, and the reason why it's commonly mistaken for a hordeolum is because tumors and hordeolums can coexist. Sometimes these tumors can cause hordeolums when the tumors or the debris will block the meibomian glands and the egress of the oil. So it's not like, is it a tumor or is it a hordeolum? Because you can have both at the same time and they look the same.
But then we go back to what Rian was mentioning, her warning signs.
That's
The
right.
structures, how the structures are affected, the lashes are telltale signs, mid margin architecture. Can't stress that enough.
Yes. Yeah, so it has been mentioned quite often in the discussion that yes, the lid margin architecture and the lashes are always a very important thing to look at, and all the other red flags as well. Okay. Um, okay, so I think we have one more question. Okay. So do we have local data on eyelid tumor or cancer statistics?
I think Rian touched on that, and also Ken. Can you just do a review, Rian?
It's the same. It's the same
It's the
publication by
same.
Dr. Eric Domingo. Go ahead, Rian.
Yes,
It's a
sir.
more complete report that you did.
Actually, that's all I found. Also, it's a 2015 study, but I'm not quite sure if there's an actual registry, Doc Gary, that we have on lid
Unfortunately not.
malignancies. No. So I think these are mostly TGH cases, Doc Ken,
Yes,
if I'm
yes,
not
yeah. It was
mistaken.
from the Perry,
Yeah,
Yes.
and
Philippine Eye Research Institute.
yeah,
10
and
years
these
study.
are post-excision biopsies. So I guess there's a bit of bias there because these are cases that were biopsied when in fact there are other tumors that are not removed. And
Yeah.
so in the urgency to have these cases removed, diba? So and this is a one center, practically one center where we get really bad cases in PGA.
So I think this
The
is an underestimated number, Sir Gary, no, of the
Yes,
cases
yes,
we have.
yes. So papillomas usually don't get sent anymore,
Yes, oo.
or yeah,
Sebaceous keratosis. Ay, yung
right. All those benign
SEP na
ones,
rin. Yes,
right?
sir.
But it is surprising that sebaceous cell carcinoma is almost as
Oo
frequently
nga.
seen as basal cell carcinoma,
Yes,
That's
sir.
right?
right.
It's
That's right.
right. I don't.
Actually, in the Asia Pacific region, in the East
China.
Asia and the Southeast Asia region, there is really a preponderance of sebaceous gland carcinoma as compared to the northern hemisphere. So we don't see. And it's also there that we see, light-skinned people, we see more melanomas than we would see here. Very rare, actually. It's quite rare to see melanomas of the skin, cutaneous melanoma around the eyelids that we see here in the Philippines.
Right.
Yes, thank you. That's nice to know, sirs and Dr. Rian. Okay, that's nice to know because I think it also will alter your index of suspicion when you're trying to diagnose a lesion that you know that this is what's more common or in what like
Right.
in white skin people you suggest this melanoma is more common as compared to basal cell or for us it's more common to have basal. Thank you for that.
Totally.
Do we have another question? Oh, okay. So can the Hughes procedure and Mustarde or the rotating cheek flap procedure for large thickness lower lid defects be done in tandem?
Use procedure.
I don't think that's necessary.
Yeah.
I don't think that's necessary. Oh, sige. Whoever
Okay.
wants to answer. I'll give my opinion also.
Okay.
Well, when you're doing I've seen a cheek rotational flap. No, it's very, it's a large flap that you can really mobilize. It will even involve the ear and go back, and you can really rotate it. So it really takes care of a large defect. But I really don't find it necessary because I'm very satisfied with the Hughes technique, and even if it's a stage procedure, um, patients do well.
Hmm. So let's break this down. So Hughes procedure, which is a tarsoconjunctival flap, and you have the mustarde, which is an anterior lamellar flap, which has the skin and muscle. So that will be a flap on a flap. Certainly, there will be very good blood supply, and you won't worry about rejection or non-taking of the tissue. So it's quite good, but it is tedious. The Hughes will entail a second procedure to release it, but it's not very difficult to do that anyway. You can do it in the clinic, actually, the release. Is it necessary? I think Ken said that maybe it's not that necessary. You can just use one flap, choose between the Starday or uh, the, the, the Hughes. But it's easier to do the Hughes and get a skin graft. I think the benefit of doing a skin flap though, is the skin tone. It will really have the same kind of skin tone. So that's why people, particularly general plastic surgeons, would rather do a flap rather than a uh, free skin graft, free full thickness skin graft. I'm open to any.
For me, I think I would worry more for the OR time if I use and a mustard at the same time, because that would, as you said, it's very tedious. Two procedures very tedious, but both are equally good. How did you describe it, Dr. Gary, before? When I was in residency, you described use tarsoconjunctival flap as an elegant procedure. It's adequate in itself. So it's very well, it works most of the time or almost all the time. So the mustarde would be nice, pero sobrang flex na yun.
Right, right. So as they say, kiss, keep it simple, right? Surgeon, keep it simple, surgeon, right? Okay, so try to use the easiest way to repair it, and sometimes that's the best way too.
Thank you for your inputs, everyone. So, do we have another question? Okay, so the next question is, what kind of ocular surface problems do you encounter after the kind of reconstruction sure? Oh, for the case, yes, the orbicularis sandwich case.
For the sandwich. Well, the what's this ocular surface? Okay, the key in doing this or any kind of reconstruction, not only for sandwich, is how you create the posterior lamella and how you suture it has to be partial thickness. It cannot be full thickness because it's really the suture that will actually abrade the cornea. Remember that bridging flap will stay there for at least 6 weeks to establish a good vascularity for the graft on top of it. So you got to make sure that your bites are partial thickness, 80%, not full thickness. Anyone else?
Anybody else? Okay.
Well, that's the question. Yeah. So it stresses the importance of getting the right tissue to cover, to replace the posterior lamellae. Some would advocate putting, some have tried using um, ear cartilage, and there you don't have the same mucosa that would protect the cornea. Some would use buccal mucosa because it replicates the kind of mucosa as in the conjunctiva. However, you don't have the sturdiness that you need for the tarsus. So those are factors, and that's why we want to get the best really is to get share the tarsus from another eyelid, or get it from an opposite eyelid as a free tarsal graft.
Thank you for that, sir, and Dr. Laganzada and Dr. Mercado. Okay, so I think that's our last question. Um, yes. Is there anything else that anybody would like to add? Or
Pwede ba humirit pa? Nag-enjoy ako eh. Last lang. For the sebaceous gland carcinoma, I always tell the residents also to check for the permanent section for perineural invasion. Because sometimes if you see that, especially in the permanent section, you would need adjuvant radiotherapy because they do recur, no? If you do enough cases, you will catch these recurrences, even if the frozen section was free of tumor in the margins, uh, and especially those that are located in the lateral canthal area. They are notorious for perineural invasion. I think that's it.
Okay. Thank you for that, sir. So that was our last question. If it's all right, thank you everyone for your questions, and of course, thank you to all our speakers, to my consultants for sharing their knowledge this evening. I hope that we were able to sort of enlighten you more with the focus of this episode, and our answers were. And the answers to the questions were sufficient for you, and that you learned even more valuable points.
Yeah, so thank you everyone again for joining us at the ITV for this section on PLO, in particular for eyelid lesions. I'm glad that you stayed, and I hope that you learned a few techniques here, some tips, some pearls from Rian, from Ken on the diagnosis and management. It's been a wonderful time we've had talking about these cases. We tried to make it as simple as possible. You know that I think we're in a very young group of oculoplastic surgeons here at the Eye Vision Institute of Medical City. We're always available should you have any questions for us to help you. We encourage the general ophthalmologists also to venture into doing some of the oculoplastic procedures, and we'll be here just in case you need us. For larger tumors, larger cases, we're here to deal with them if you need it. So thanks again, Pia.
Yes. Okay. So thank you again, everyone. And I would just like to say that I really learned a lot as a fellow. I really learned a lot again, and I just hope one day to be as great as an orbit and oculoplastic surgeon as well. So, with that, I would just like to remind everyone to please fill out our attendance and evaluation form by clicking on the link that is posted in the comments section. So, we hope you tune in on the next episode of TMC ITV, which will be on March 18, 2021 at 5 p.m. Philippine time. So, again, thank you for tuning in to the 14th episode of the Medical Cities digital platform, ITV. So, thank you to our Oculoplastics and Orbit section of the TMC Eye and Vision Institute, especially to our speakers, Dr. Lagunzad, Dr. Perulan, Dr. Pasco Rosete, Dr. Shapno, Dr. Valencia, and of course to our moderator, Dr. Gary Mercado, for gracing us with their presence today. So again, this is Pia Texon on behalf of the Orbit and Oculoplastic section of TMC ITV. Signing out of TMC ITV, Ophthalmic Instruction Without Borders. Good evening, everyone.